Welcome all to Chapter 18, where we will be looking at preconception and prenatal screening and diagnosis. Prenatal screening methods aim to identify pregnancies at risk for genetic disorders. Screening is particularly relevant for neural tube defects and chromosomal aneuploidies, such as Down syndrome. We'll look at both maternal serum screening and newer techniques, like cell-free fetal DNA analysis, which offer non-invasive options with high sensitivity and specificity. Neural tube defects, or NTDs, have a high incidence even without a family history. The maternal serum alpha-fetoprotein, or MSAFP, test is performed around 16 weeks to detect open neural tube defects like spina bifida. High AFP levels are a warning sign. The MSAFP test is often combined with an ultrasound for improved accuracy, with anatomy ultrasounds becoming the primary tool for NTD screening in many centers. Most children born with trisomies, such as Down syndrome, are born to women without apparent risk factors. Early screening tools combine serum markers with ultrasound, but more recent advancements include cell-free DNA, or NIPT, which is highly sensitive for detecting common trisomies as early as 10 weeks. This technique has revolutionized prenatal screening, offering a less invasive option with high accuracy. First trimester screening, performed between 11 and 13 weeks, combines serum markers like PAPPA and HCG with neutral translucency ultrasound. These markers provide insights into trisomy risk, including for trisomy 21, 13, and 18, as well as 45 DEX. This combination of markers and ultrasound is a strong early predictor for chromosomal abnormalities and certain birth defects. In the second trimester, the quadruple screen includes HCG, MSAFP, unconjugated estriol, and inhibin A. These markers vary depending on the trisomy type, providing risk information for Down syndrome and trisomy 18. Adjustments are made for factors like maternal age, weight, and smoking status to improve the test's accuracy, particularly for patients who missed first trimester screening. NIPT, or non-invasive prenatal screening, uses cell-free fetal DNA from the placenta found in maternal blood. This screening can be done as early as 10 weeks and has very high sensitivity and specificity for trisomies 21, 13, and 18, as well as sex chromosome anomalies. It's important to remember that NAPE is a screening tool. Positive results should be confirmed by invasive testing like CVS or amniocentesis. NIPT relies on high-throughput sequencing to count DNA fragments and detect aneuploidies. Although highly accurate, it's still a screening test. Positive predictive value, or PPV, is lower in younger women, but negative predictive value remains consistently high across all ages. Future developments may expand NIPT to screen for a wider range of genetic conditions. Ultrasound remains a core tool in prenatal diagnosis, allowing assessment of fetal growth, viability, and morphology. Traditional 2D ultrasound is standard, while 3D and 4D ultrasounds provide more detailed imaging, especially for complex anatomical areas like the fetal heart. MRI is also available for high-resolution views, useful for hard-to-detect anomalies, particularly in later pregnancy. Certain ultrasound findings, or soft markers, suggest chromosomal abnormalities. These can include cystic hygromas, heart defects, or limb abnormalities. When multiple markers are present, the likelihood of aneuploidy increases. Further testing, including genetic counseling and invasive testing, is usually recommended for a more definitive diagnosis. Ultrasound can also suggest specific single-gene or multifactorial disorders, such as skeletal dysplasias, which guide clinicians in selecting targeted genetic tests. However, ultrasound cannot identify disorders that manifest later, or those focused on intellectual disabilities, limiting its diagnostic scope for some conditions. Prenatal diagnostic procedures like amniocentesis and chorionic villus sampling, or CVS, offer definitive genetic information. These tests are typically indicated for advanced maternal age, family history of genetic disorders, or abnormal screening results. ACOG recommends that all women have access to these options, regardless of age, alongside non-invasive options for those preferring to avoid invasive testing. Primary indications to prompt a clinician to decide on performing prenatal diagnosis can include advanced maternal age, or AMA for short, family history of a genetic disorder or previous child with a chromosomal abnormality. A parent or both parents can also be carriers of a genetic abnormality, and this can mean there is a chance of inheriting the abnormality. Lastly, high-risk pregnancy due to increased neutral thickening can also be a big reason why prenatal diagnosis takes place. Amniocentesis, typically done between 16 and 20 weeks, involves using ultrasound to guide a needle into the amniotic sac to collect fluid for analysis. This fluid can be tested for chromosomal abnormalities, single gene disorders, and neural tube defects. Ultrasound guidance ensures fetal safety and allows for precise sampling. While amniocentesis is generally safe, there is a small risk of miscarriage, approximately 1 in 900 above baseline. Other rare complications include fluid leakage or infection. Early amniocentesis, done before 16 weeks, has higher risks and is no longer recommended due to complications like fluid leakage and clubfoot. CVS, performed between 10 and 14 weeks, involves collecting placental villi tissue for analysis. It offers earlier results compared to amniocentesis, but doesn't assess neural tube defects. Chromosome analysis success rates exceed 99%, though there is a small chance of mosaicism, which may require further testing. In the next few slides, we will be looking at the types of prenatal diagnostic tests performed in the lab. Lab tests for chromosomal abnormalities include karyotyping, FISH, and chromosomal microarray analysis, or CMA. CMA has a higher resolution for detecting copy number variants and is recommended as a first-line test for fetal abnormalities found on ultrasound. Rapid FISH analysis offers results within a couple of days, but it's limited and often followed by karyotyping or CMA. Low-coverage whole genome sequencing is increasingly used outside the U.S. for prenatal testing. Single-gene sequencing, gene panels, and exome sequencing help diagnose single-gene disorders when there is a known family variant or unexplained fetal anomalies. Trio analysis, including both parents and the fetus, improves interpretation, especially with incidental or uncertain findings. Biochemical assays, used for prenatal diagnosis of metabolic disorders, analyze samples from CVS or amniotic fluid. These tests detect protein abnormalities which DNA testing might miss. Specialized labs handle these assays, as they require advanced techniques to confirm functional protein deficiencies in over 100 metabolic conditions. The challenges in prenatal chromosome analysis and gene sequencing. Challenges in prenatal chromosome analysis include mosaicism and maternal cell contamination. True mosaicism, which appears in multiple colonies, may be present in the fetus, whereas pseudomosaicism is limited to culture artifacts. Maternal cell contamination, often detected in CVS, can be managed with careful sample handling and maternal blood comparison. Confined placental mosaicism, or CPM, involves abnormal cell lines in the placenta but not the fetus. This can result from trisomy rescue, potentially leading to uniparental disomy. Confirmation may require follow-up with amniocentesis, as it's challenging to assess CPM's clinical relevance solely with placental samples. Rarely in the lab would we have a cultural failure, which yields no results for the patient. In that case, we would investigate the reason behind this failed test, whether it is due to low DNA yield, a reagent issue, or human error. We can then rectify the problem and either retest or ask for a new sample to test if the issue was due to low sample yield. Another problem could be due to maternal cell contamination, which is an issue with chorionic villi samples and not amniotic fluid samples. This can be prevented by dissecting the sample carefully and removing any maternal tissue from the villi of the placenta. Incidental findings, particularly variants of uncertain significance, VUS, are common in chromosomal microarray and sequencing. VUS findings complicate counseling, as their significance may be unclear. Incidental findings can also reveal unrelated health risks, and families may choose to receive or opt out of these results. In the next few slides, we will be looking at preconception genetic screening. This is where testing takes place before pregnancy. Carrier screening, ideally done preconceptionally, identifies parental genetic risks for autosomal recessive or X-linked disorders. ACMG recommends screening for a broad panel of conditions, regardless of ancestry. Carrier couples have reproductive options, including pre-implantation genetic testing, which screens embryos for genetic conditions before implantation. Pre-implantation genetic testing, or PGT, screens embryos created through IVF for genetic disorders. PGTM targets single-gene disorders, PGTA screens for aneuploidy, and PGTSR assesses structural rearrangements. Advancements in next-generation sequencing have improved PGT's accuracy, though confirmatory prenatal testing is still advised. There has been a big shift in testing from using techniques such as microarray and FISH to next-generation sequencing. This is largely due to the better accuracy, and the cost of testing is always reducing due to the high demand. There are, however, some limitations and ethical considerations which need to be looked at prior to performing such an extensive and informative test. Fetal interventions began with intrauterine transfusions and now include surgeries for spina bifida, twin-twin transfusion syndrome, and congenital heart conditions. Medical therapies, such as antiarrhythmics for fetal arrhythmias, are also available. New treatments like gene therapy and stem cell interventions are emerging for select genetic conditions. A multidisciplinary team is essential for fetal interventions, including genetic counseling, prenatal testing, and detailed assessments. Counseling supports informed decisions by addressing the risks, benefits, and ethical considerations involved. This team-based approach ensures the family receives comprehensive care tailored to their needs. Thank you for taking the time to go through this lecture.